Good morning. I now convene this morning's hearing entitled Where Have All the Patients Gone? Examining the Psychiatric Bed Shortage. Doctor, you're next.
Mr. Chairman, Representative, ladies and gentlemen, good morning. I am Dr. Jeffrey Geller, a board-certified psychiatrist, currently professor of psychiatry at the University of Massachusetts Medical School, medical director of the Worcester Recovery Center and Hospital, and staff psychiatrist at the Carson Community Mental Health Center. I have consulted the public mental health systems and state hospitals in one-half the states in the United States, the District of Columbia and Puerto Rico. I am the author of 250 publications in the professional literature and the book Women of the Asylum. I serve on many professional boards, but I come here today representing only my own experience taking care of patients with serious mental illness for 40 years. Just yesterday, there were 22 psychiatric patients in a general hospital emergency room in a city of 150,000 not far from here, waiting for a disposition. Why? What's to be done? On May 3rd, 1854, President Franklin Pierce vetoed a bill that would have made the federal government responsible for America's population with serious mental illness. His veto message includes the following beliefs of his. State hospitals or public psychiatric hospitals are meritorious institutions doing good. They fulfill a historic role belonging to the states, meeting the needs of a population outside the purview of the federal government, and susceptible to becoming the responsibility of the federal government if the federal government provided any opportunity to the states to shift the burden. The federal government left the care of the serious mentally ill to the states until Congress passed and President Kennedy signed the Mental Retardation Facilities and Community Mental Health Centers Construction Act of 1963. From then until now, federal actions such as Medicaid, Medicare, the IMD exclusion, and many others have resulted in the unintended consequences of massive proportions, not the least of which is deinstitutionalization. We created the perfect formula for the current debacle, an expanding array of fiscal incentives for states to move people out of state hospitals, inadequate resources to meet the needs of state residents with serious mental illness in the community, no beds in state hospitals to meet the needs of former state hospital patients who did not find the community the panacea promised by the Supreme Court and were dangerous outside of hospitals, no beds to meet the needs of new cases of serious mental illness requiring hospital level of care, and a public more willing to build jails and prisons than hospitals because they found no solace in a state system they saw as pushing ill-prepared folks with mental illness into their neighborhoods. How does this lead to individuals waiting in hospital emergency departments or EDs for weeks, sometimes a month? Pick any state. There are no available beds in the state's public psychiatric hospitals because there are too few beds. A patient on the psychiatric unit in a general hospital has been approved for transfer to the state hospital, but cannot be transferred because there's no available bed. Thus, the general hospital psychiatric unit is populated by some patients who are stuck there, awaiting state hospital transfer. An individual is brought to the general hospital's emergency department by police, family, ambulance, or comes on her own. The individual is assessed and determined to need hospitalization. The individual cannot be admitted to the psychiatric unit in the same hospital as the emergency department because there are no beds there. What happens next is a hospital emergency department staff or a member of a contracted crisis team starts a bed search. A bed search means calling every hospital in the state seeking a bed. Frequently, the bed search is fruitless. There's no beds available anywhere because all the hospitals are in the same situation as the psychiatric unit and the hospital the worker is calling from. So the individual remains in the emergency department waiting for an available bed. The days of waiting benefit no one. The ED becomes overcrowded. The patient is a patient in name only. He is not getting treatment, except that he is receiving food, a bed or gurney, and maybe some medication. He might as well be waiting on a bench in a train station. Or the individual is simply released from the emergency department because there's no place else for her to go. The threshold for holding somebody in the emergency department awaiting admission keeps creeping up. Many released folks are picked up by the police, processed through the courts, sent to the state hospital for a forensic evaluation, further decreasing available beds to the person awaiting a bed in the emergency department. Congress can enact measures to ameliorate the problems of boarders in emergency departments. These include provide states with opportunities to obtain IMD exclusion waivers with maintenance of effort. Make SSI and SSDI payments to eligible individuals independent of where they reside, and require their contribution for room and board to be the same in all locations, including jails and prisons. Individuals keep their Medicaid and Medicare in all settings. improve the federal grant process for research into prevention and early intervention, provide grants to states to create or expand crisis intervention teams so that such a program is available in every city and town, set fair and reasonable Medicaid payment rates for psychiatric services at community mental health centers and federally qualified health centers, incentivize states to actually use the assisted outpatient treatment statutes they have, define Medicaid and Medicare payments to clubhouses in ways that do not destroy the mission of clubhouses, incentivize states to establish mental health courts. Mr. Chairman, representatives, it's time the federal government took explicit action through bipartisan, bicameral efforts to remedy the calamitous state of the public care and treatment of persons with serious mental illness in the United States today. Thank you.
Thank you, Dr.